Surgery and Pediatrics at GW here and is part of our team of our fetal team. And Dr. Eva Rubio or I, Dorothy Bulis, will be supporting the imaging of this fascinating topic. So thanks, Andrea, for starting. Please remember, for those who have called in, we will have time for questions and answers at the conclusion of the exam. We have a very compelling question in the middle. You can also come in and ask a question. So thank you, Andrea, for coming, and we can get started.
So with a background that kind of helps us understand some of the challenging limitations when it comes to predicting treating severity or the range of severity that we see in CDH. So the frequency of this anomaly is somewhere between 1 in 2,200 or 1 in 2,500 births. The majority of defects are going to be left-sided, and so the defect really occurs in the posterior lateral aspect of the diaphragm. Treatment from centers that have standardized protocols, and we'll get into that a little bit in this talk. For their survival is as high to 90%. But once these infants go on ECMO, their survival becomes a coin toss, and it's 50%. The primary determinant of the morbidity and mortality in this disease is pulmonary hypoplasia and pulmonary hypertension. And it's useful to break it down into these terms because it goes to how we counsel and also the difficulty of it, in that pulmonary hypoplasia really refers to the lungs just being small. And not only are they small, but the branching, the bronchial branching pattern and the alveolar surface area is really pruned back so that there isn't as much of that surface area for gas exchange. The vascular bed is also abnormal. And so that normal pulmonary should be very thin-walled, not a lot of muscularity. And in the recent picture, you see that the arteries in CDH are very over-muscularized, which leads to their pulmonary resistance. And then they're also very reactive. And we don't have a good way of directly assessing that. And so when we talk about pulmonary hypertension, we're really talking about that dysfunction of the lung that we really challenge to treat postnatally. Defects, about 2/3 of them, I would say, are diagnosed prenatally. So that's okay. At the time this talk was presented, that was the reported.
Really small, or is it because we're just not very good?
Good question. Okay, so they're obvious. You know that you have stomach up in the chest is pictured here, or you see a lot of bowel in the chest. Some little where you have maybe just a little bit of fluid, or it's a right-sided defect, and the difficulty of determining the interface between the liver and the lung. Sometimes you just have to be very suspicious because all you might have is a little bit of pleural fluid. For those reasons, and that's how I tend to miss them. Classic. So with our prenatal imaging, there are a variety of indices that we try to employ to gauge the severity of the disease postnatally so that you can adequately counsel and prepare parents for what's ahead of them. Liver position has been sort of the most tried and true. It's the most simple. Either liver is up in the chest, indicative of a larger defect, or it's retained within the abdomen, indicative of a smaller defect. So liver position with liver is worse than liver in the abdomen. In this class, depending on training, the lung-head ratio. Talk about the observed to expected lung-head ratio, and then those being all ultrasound measures, and then the PPLV, which is the percent predicted lung volume, which is an MRI measurement. And then it's important to note that all these predictions and their associated survival really applies for the isolated CDH. So that almost anything else in addition to GDH, you'd be a much different outcome.
So there are a few predictive rates that we can calculate in evaluating these patients. Probably the well-known one is the lung-head ratio, where we calculate the area of the viewable right lung and also use the head circumference to calculate a ratio. Now, there are several ways to do the lung-head ratio. The one you see here is what we call the longest length ratio, and this is where we basically take the longest possible length of viewable tissue at the four-chamber level of the heart, and then we do the second line perpendicular to the first line. So that's probably the easiest way to do it, and it's probably the way that most people do it. There are ways. One is called the San Francisco method, and the first line is drawn perpendicular to the sternum, which is always a little bit tilted because of the congenital diaphragmatic hernia, and then they draw a line perpendicular to that. The other, which I haven't seen very many people doing it, is actually just drawing around the viewable lung tissue and getting an area that way. With most PAC systems, that's actually pretty simple to do, but I still find that the longest length method is the easiest way to do this. So if you get lung-head ratio, and it's all done in millimeters, 0.6, the survival is almost 0. If you have a lung-head ratio greater than 1.35, you have very good survival chance. But that doesn't prove to other things that come along with congenital hernia. But it should also be noted that because as pregnancy progresses, the lung grows about 4 times more quickly than the head, straight lung-head ratio is okay early in pregnancy. As the pregnancy progresses, we should be using an observed to expected lung-head ratio. This is something that in order to have a certain amount of consistency within the institution, it helps to have a lot of experience. It's also one of the moments for sure where it helps to have the radiologist actually go in and help the sonographer get the right view to calculate a lung-head ratio. So tables available online to get the observed to expected lung-head ratio, which will correct for the fact that the lung is growing exponentially more quickly than the head during gestation. And this becomes much more accurate in predicting the survivability. The ratio that can be used in MRI is called the PPLV, or percent predicted lung volume. This is a concept that was forwarded by Carol Barnewalt of Boston Children's back in 2007. And it's sometimes a little confusing what this ratio is calculating. So here's the way I like to explain it. How much lung the fetus, not you as the radiologist or obstetrician, but actually, how much lung the fetus actually has and how long they're supposed to have. How much lung they actually have is calculated by just drawing slice by slice and getting the total volume of the right lung. That's the easy part. And left lung, that's a little bit harder because you're sort of competing with boobs and thymus and other mediastinal structures. And so we calculate how much lung they actually have and how much lung they're supposed to have. Now, how do you calculate that? Well, basically what we do is we get the total lung volume as it would have been if they didn't have a congenital diaphragmatic hernia. And how do we do that? We sort of imagine where that diaphragm was supposed to be, and we draw this over, and we get a total thorax volume, and then we subtract out the mediastinum, and this is how much lung tissue a fetus at that gestational age is supposed to have, and we multiply it by 100. So I find this very useful. It is one of the benefits of MRI, however, and in a particular institution, I think it takes a little bit of practice to get everybody on the same page, measuring the same way, and drawing the lines slice by slice the same way. So found on this scatter plot, they show that a lower PPLV is significantly associated with a prolonged hospital stay. So as the PPLV goes and gets into the teens, the length of stay increases, And here on this bar graph, they show the survival of patients according to their PPLV. And PPLV, percent predicted lung volume of less than 15% is associated with a significantly lower survival. So that's the benefits of MRI. What else would we do? An MRI for a fetus with congenital diaphragmatic hernia with advanced ultrasound imaging? I think that's a fair question. So here are some of the reasons that I could come up with, although clearly I can't count because I put number 5 down twice. I have on several occasions discovered lung lesions of the congenital diaphragmatic hernia, and these can be a problem. Occasionally they present with complications later. And so to distinguish between a lung lesion and lung tissue that is compressed is difficult without an MRI, and sometimes it's even difficult with an MRI. To define the liver herniation, both with the T and T2 weighted sequences. Sometimes it's difficult to tell the difference between the compressed bowel and the compressed lung and the liver, and I find MRI is especially helpful for that. Some of these patients present with syndrome, so detecting all of the additional and subtle abnormalities is important. Occasionally we find that a fetus has a sac-type hernia, and that is best defined with I think, over ultrasound. We discover misdiagnoses. Sometimes CHs are confused for CPAMs and vice versa. We have cases of bilateral congenital diaphragmatic hernia, and usually one of the hernias on one side is very obvious and the other is smaller and more subtle. But if we confirm that there are bilateral congenital diaphragmatic hernias, that's very helpful for counseling because that's considered lethal. Possibly the least important reason, but most important when you're in the room with the family, I find that the MRI images are very helpful for counseling with the family. It's much easier for them to make sense of the fetal images by MRI than it is by ultrasound.
So a little bit about sort of approach things here based on the patient's comprehensive counseling, and they're going to get a sheet with some diagrams that's going to go over the pathophysiology that we talked about, and then we're also going to list their predictors here and then try and put them on this somewhere on this spectrum of severity so they can have an understanding of what's you're better at identifying the extremes of the spectrum, the very bad and the better. But the reality, these percentages up here, so the patients are going to fall right in the middle. Broad spectrum to kind of counsel within, and it speaks to the limitations of our prenatal predictors in that we're only measuring lung size and we're not directly assessing the pulmonary vascular bed. The families are going to, when I'm talking to them, I spend a lot more time talking about ECMO if the LHR is less than 1.4, and if they have a better prognosis based on the falling in this range, then we're going to touch on ECMO, but we're not going to dwell there and spend a lot of time talking about the details of it. Get a lot of monitoring in their pregnancy. This is just kind of what the protocol was where I trained, where you start doing ultrasounds every 2 weeks at 20 weeks and weekly biophysical profile starting at 34 weeks. I bring up Fetal, a topic that a lot of people start to question when your patients fall in this with poor outcome, and that's referring to the Fetoscopic endoluminal tracheal occlusion treatment. The idea here is that you can deploy a balloon within the trachea that blocks the egress of fluid, increases the pressure within the tracheal bronchial tree, which promotes cell proliferation, better maturation of the lungs. This is reserved for an observed to expected HR of less than 25%, and going back to that observed to expected table, and the bar really breaking it down into the in the chest, and then the blue is liver. So the prognosis or the survival within those two groups is different. If the observed to expected is less than 25%, you're really talking about the most extreme cases of CDH, and that the balloon inserted between 10 and 30 weeks to promote that cell proliferation, but then removed at 34 weeks before the baby is delivered. that cell proliferation is not quite normal. There's a decrease in the number of type 2 pneumocytes and therefore surfactant production. The studies that were done in Europe that compared to historical controls show survival from 24% survival to, and so if you're looking here, change the survival from one group and kind of upstage it to the next group of moderately severe as a best case scenario, but at the risk of inducing preterm labor and then trading for the problems of prematurity. The U.S. is yet to get an FDA approval device, and so we've been kind of in this standstill to start this total. One place that I know that do compassionate care, and they have some devices, but they don't talk about how they get the devices. But really, it's just something that's done on study, and it's not at this time. Talk about the conventional modern day postnatal management because it's different than what was compared to the fetal group, and really the kind of this that makes it successful is the idea that you're going to standardize the treatment protocol. So all of that, 80 to 90% survival is coming from centers with a dedicated program that have gone through and standardized their treatment protocols. And that's at every step. What do you do in the delivery room? What's absolutely necessary? How do you streamline transport and get the babies to the definitive care institution with the least amount of stress? And then once you're in the NICU, what do you mean? And really at the core of that is the idea that you're going to employ gentle ventilation strategies. Just enough pressure to expand the lung and have gas exchange. You're going to have defined treatment goals that these kids are not all to have 100% SATs. We're going to accept SATs of 85, 90% as long as the end organ perfusion is good and there's not acidosis. And we're going to standardize our ECMO criteria as to who goes on. Some of that is obvious, but then also the idea that if you're having to use induced ventilator settings to achieve those goals, then the criteria to go on to ECMO. The advantages of those protocols, we've seen that increased survival, going from the 60s and 70% ranges up into the 90s. The study that looked at this at their institutions reported decreased ECMO use. I think it probably changes the population of kids that are on ECMO and just more appropriately targets those that really need it. You see variability in the decision-making between providers, and then they also really talk about the benefit of laying out treatment goals so that for every level of care, from the nurses at the bedside, understanding what the goals are and having a uniform approach. The surgical repair, sometimes patients are surprised that doesn't occur right away. And so to me, the part about the surgery is picking the right time to do it. With significant pulmonary hypertension, we're really going to do that through an open approach using an incision in the abdomen to bring two edges of the available diaphragm together, and if there's not enough diaphragm, we're going to impose a patch in between so that there isn't as much tension across that reconstruction of the diaphragm and that repair. If pulmonary hypertension has had an opportunity to stabilize, if not resolved, and the kids are able to come down on their ventilator settings to a reasonable level, able to top surgery and anticipate that they're going to have some increased support needs immediately after surgery and that you have some place on the ventilator to go. At our institution, we do the repairs off ECMO. Other institutions use devices and actually repair on ECMO. Some bleeding risks. Like that the babies have shed a lot of their edema. That's an indicator that, again, they're ready and that their acid-base balance is normal, again, that they're ready for the stress of surgery. Increased survival rates. We see there are a lot of long morbidities in this population that really need to be addressed. Fall into three general categories: GI, nutrition, pulmonary, and then neurodevelopmental. And so when we get the more severe groups, that middle 80%, that moderately severe, and then the most severe, and usually if they've been on ECMO, that automatically makes them severe. They have a variety of problems that are really best addressed through multidisciplinary follow-up programs and early intervention strategies. Just kind of a start point for some of the centers that have really effort into making these multidisciplinary clinics. The number of appointments and the follow-up, this is just a start point these kids will have. And the first year of life, they're seeing their surgeon, they're seeing their pulmonologist. By really talking about the development effects that are important and dominate that first year, and nutrition. These kids breathe, they spend a lot more energy to breathe, and so their growth and nutrition is so they need a lot of special attention. We'll see these provided multiple times during this time period, but these are minimum that most of the follow-up would require. And then as they get older, they're still seeing their pulmonologists, and they're going to get a variety of testing, including pulmonary function testing and in some centers VQ testing, because we see that as some of these kids are getting older, they're developing exercise intolerance because of that, again, that pulmonary vascular bed compromise. A lot of the literature that's coming out now is looking at these patients and long-term follow-up and to the adolescents and stuff, the data that we have from those larger centers.
So that function gets worse over time?
It doesn't. What is that once they're 15, 16, 17, 18 years old, that they have exercise intolerance. And then if you go and do VQ testing, the pulmonary vascular bed is not there. The perfusion is not there to the lungs. So some of these severe cases, maybe 98% of the flow going into the right lung, and the left lung has nothing. So you have significant VQ mismatch.
And for the surgical visits, do they get like baseline radiographs? We don't seem to do much else with like CT.
So the recurrence rates are highest within the first 2 or 3 years of life, and most will do an annual X-ray surveilling for recurrences. Take-home points at CDH is a broad spectrum of severity. It depends very much on the pulmonary hypoplasia, pulmonary hypertension. We have a hard time predicting what that pulmonary dysfunction is going to be because we have yet to find a way to direct measure or assess that prenatally. The liver position and the observed to expected HR are really the best predictors that we have at this point to kind of assign those patients into those broad categories. Post-treatment protocols improve survival, so one of the important aspects of coming to a fetal center is getting plugged into a program that has those protocols in place. And children with moderately severe CDH have complex long-term issues, and from those multidisciplinary approaches where you try to cluster appointments and make sure they're getting to these appointments at their recommended time periods, and so that they can have early intervention strategies employed for them.
Thanks. Mute your phones for those of you who have called in. If any of you do have questions, we're happy to answer any of them.
Can I just quick about the liver up story? How much liver has to be up for it to be liver up?
So there's no defined criteria. So it's the reason if you just have a little bit of the left upper lobe, that's not going to hold as true.
Mm-hmm. But any liver above the diaphragm is considered bad, right?
I think it's starting a percentage. They're trying to do some volumes as well, but I think each little bit is really just a story.
I think it's very common to see only a tiny bit of liver up. Liver is usually either up and really up or not at all.
And then do the surgery and bring that piece of liver down. Is that a functional piece of liver? Vascular issue?
No way to really know. There is some mobility in that retroperitoneal surface, so often the kidney floats up too, and you can really retract down and be able to close the diaphragm above it. The liver is pretty dysmorphic that comes through, so sometimes the contours of it present a challenge for getting it to come down into the abdomen. But
logically, the shape of the liver is a function of this.
Right.
So if it goes under the diaphragm, that's why it gets that dome shape. It's out in the infallacy, like here.
Yep.
So I can see where it would mold.
It can look quite funky.
Yeah.
If we tell you that the spleen and kidney and what bowel is up there, or you deal with it, you're going to push it down. And do you want to comment a little bit about the difference between a primary pair and the, I guess, the yeah.
So, yeah, it's just a thin muscle, so we don't on the imaging. We struggle with this all the time when we see questioned ventrations and hernias with sacs, and kind of the reality is in the operating room, that's the first time you're going to be able to see what's the quality of the diaphragm by looking, feeling it to see how much you have in the thickness and a true muscle fiber to put a stitch through. If the diaphragm is curled up upon, then you can dissect it out and straighten it out. And there's not enough to come together with tension, because if you put tension into your air, it's going to fail at some point. Then we put a patch in to take away that tension but reconstruct the diaphragm. And the thought is that the rib diaphragm around it grows with the child, so it's not like you have to go in there and replace the patch. And the patch gets peritonealized, so it actually has a membrane that's biologic over time. You know, a lot of studies look at kids who get a patch repair versus those that don't. It's really, again, just obviously the kids that have a patch repair are going to be more severe because the defect is bigger and there's more in the chest and there's more mass effect and more pulmonary hyperplasia and hypertension.
So for the feto surgery, so the is that this will be less invasive because they'll be doing it endoscopically, so the incidence of premature delivery should be lower. Do you think FDA trial is really going to be coming about, or what is it for the future?
They do it late anyhow, don't they? And 27 weeks is very late in pregnancy.
I think the problem is we don't really know. You know, we're going off of historical controls in Europe as that comparison group. It's not against what a conventional therapy is. And I haven't done the procedure myself, but I think if everything's in line and favorable, it can be very quick, you know, a matter of minutes, and then you can struggle for hours and hours to get the right position to deploy the balloon. When you deploy the balloon, then those children are going to have to be followed at that center because they can't be delivered just anywhere because they have a balloon. So that balloon has to be removed, and if they deliver emergently or prematurely, then there has to be somebody available who can deal with that balloon. So I think that when we do this study here, that's when we know, is it really better than current treatment?
Have they started the study here or not yet?
No, so the holdup has been, I understand it, the approval of the device by the FDA. The places that do it have been able to get these devices from some way that they don't want to talk about, and they use it under compassionate care.
The trial that's going to be done here a direct extension of the European trial, or is it modified?
It's modified, but with their input. And my understanding is that the centers are going to be involved in the study, sent surgeons over who have done the training, just sitting around waiting.
So I have a post-op question. Nitric oxide used often in these patients, or not so much? Yeah. And then there's citrulline levels.
Do you know anything about that aspect of it?
No. So the reason I'm asking is citrulline is a precursor for arginine, which is the precursor for nitric oxide. And we know that in heart defects, individuals with lower citrulline have nitric oxide production ability. I'm thinking about a group of individuals who have a gut to absorb the amino acid, and may at baseline have lower nitric oxide and have the risk of pulmonary hypertension. I'm just wondering whether or not a therapeutic option would be at least figuring out if they're getting appropriate diet management.
So about the nitric oxide CDH story, that we use it a lot because we're quite desperate when it comes to pulmonary hypertension. But in the CDH population, don't really have a lot of true responders. But it's very hard to reserve that therapy or start it and then take it off. And so we use a lot of nitric oxide that may be unnecessary.
I'm just wondering if you went from the back end, maybe you'd get some responses. Citrulline deficient makes your make nitric oxide on the other side, but you've got those thick muscles, which means.
Would there be a role for just forgetting about whether it's normal or not and just giving it at higher doses?
Well, so there's no risk of it, assuming you don't have somebody with a urea cycle.
Yeah,
It's a whole other can of problems.
They would have having a CDH and urea cycle defect. There's a message in there somewhere.
But, I don't think that there's a problem with that. Is that IV citrulline is still a patient use protocol. It's not available. Arginine is available, but arginine doesn't cross quite as well. You need the citrulline to line up the nitric oxide. And they've used it in heart surgeries, predominantly in adults, and shown that you shorten time in hospital, you shorten time on ventilator.
Crossover what?
So arginine doesn't enter the cytoplasm quite as effectively as citrulline does because of transporters. And it need to enter into the complex earlier than where arginine would enter in, because that complex is either going to be nitric oxide synthase or it's going to be arginase. Right? These are 2 steps before, which is where citrulline is.
I think area that we really haven't touched base as an imager, the most frustrating thing I have is it's a pulmonary hypertension issue and how we can be better at kind of assessing it. So be comfortable in assessing a severe hernia, but again, as you mentioned with the even when the ratio is not too bad, there still is a subgroup of those that still not doing well because they both have severe pulmonary hypertension. I think that's an area that we need to do better with. People have been struggling. That's why we're doing the hyperoxia test now. In this patient population, there are some, like the McCune measures pulmonary arteries by MR. We can measure them, I guess, on echo as well in the 3rd trimester. I think that's really a very key area that perhaps we can get better with in the future. I think the response isn't in concept. We just have to actually work, but find the most heartbreaking part of these patients. My first fetal MRIs years ago were because of the hernias, and we first with the nitric oxide and with the liquid ventilation, and then with the fetal surgery. Each time we thought we were getting somewhere, and years better, but we're not quite there yet.
It's still frustrating.
It's a very great diagnosis, so we're and not really what we tell you, because it still is a little bit of a guess.
And in terms of prenatal predictors, you said that the OE blinded ratio is more accurate later in pregnancy. When do you suggest eventually to repeat this ratio? Because, usually we see here patients around, after the 22 weeks, 24 weeks. Do you recommend to repeat eventually after 30 weeks?
It's hard what the right answer is to that question. Because that middle group is so broad, we rarely see that that indices to change their group. They're still going to get very much the same counseling, the same management, and so it's hard to say that we need to be repeating those measures at that point. Like the utility is making the initial diagnosis and then giving them that broad sketch and brushstrokes of what they're going to learn, because there's a lot of variability within that, and they need to know about ECMO, and they need to have a general sense of how long they're going to be in the NICU and what those long-term things are. And measuring the expected LHR, again, doesn't change that.
The ratio was more, I think it was, but it's not that it's more predictive later in gestation. I think all of the HR data is from that 20-week, 22. So seeing them later, then the O to E is a better measure than using the straight LHR number.
We do both. Just because the original data had LHR in mid-gestation and then showed that the up to expected is better in the gestation, we're doing both, and they should be concordant. It's that in the third trimester, the lung outpaces the head growth by fourfold, and so just measured LHR alone, it would always look better in the third trimester artificially.
You're thinking about following, but also cost and what it's going to do, in our and it's very important to make a diagnosis before 22 to 4 weeks, but once you make diagnosis, I think we've already decided we're going to deliver them. So a slight change in the ratio in the third trimester may not matter. I think in Europe it's a little bit different because they may be going to these feto centers at 27, 30 weeks. So they have these centers, I guess, of delivery. So it may make more sense for them to be dependent a little more on the third trimester studies because it's where that patient's going to actually deliver what approach they're going to do. So their data has been looking particularly at the third trimester, and that's where I think is MR actually is better with the ratio.
To supplement the mother to raise protein levels in the fetus?
Well, we typically say that giving citrulline giving amino acid to a mother doesn't really change the fetal exposure. And because we're used to trying to talk about a fetal with a disorder,
Mm-hmm.
I
see.
right?
Yeah.
And so I
metabolic with an enzymatic disorder.
with an enzymatic disorder, because that's usually, I'm not sure we've looked at individuals with normal biochemistry, whether or not taking more of a supplement will change the normal ratios. Very specific ratios that our body maintains, otherwise we get rid of the extra amino.
The ratio you're talking about is the ratio between the mother and the baby. If you
But
raise
also,
the mother's level, you'll raise the...
But be successful in raising mom's level, because my
I see.
may not uptake the extra, you may dump it.
Yeah.
And so you may not be able to transfer that up. You get temporary increases, but you're never going to get
Efficiency, though.
Yeah.
No, but I'm just wondering whether more is better supernormal.
Well, I think what it does tell us is we have to maintain protein delivery to the infant after delivery. So really cognizant is TPN, because I assume we're not feeding. Really cognizant is getting TPN started as soon as we can and moving it forward in terms of the tricky part is when they're on
But that pulmonary hypertension sort of gets into a cycle, right? And it's much easier to, it's much you can prevent ever getting there than trying to reverse
Well,
it. Right?
that's why it's so important to streamline and manage the delivery and transport. Because once they spiral, it's very hard to break them and very susceptible to it. So it's the dope, don't poke the skunk.
feed the baby.
Thank you so much. That was great. And,
Any out there?
we'll have, next month will be Dr. Vizina talking about supratentorial abnormality of the fetal brain. And August we'll have a nice presentation with Dr. Silber and Meg on ethics counseling.
Thank you.
Sorry, we had an MRI crisis in the middle of checkout. Because I'm post-call, I was checking out the resident, came in early. And we get bombarded with calls. And then Dina calls me with total, like, GIT crisis. And